This is Selma Schimmel for Advocacy in Action in Chicago at the 2012 Multidisciplinary Symposium in Thoracic Oncology, brought to you by ASTRO, IASLC, ASCO, and the University of Chicago.
It is important these days to secure that we have good quality tissue for molecular testing.
We still encounter a number of barriers for tissue testing. For example, if a patient has a biopsy at a hospital and comes to another institution for a second opinion where testing is recommended, it's not straightforward that you can get the tissue from the other hospital. Some hospitals would release slides, some won't release the blocks. So there are many barriers still that exist, even though I think the thought process is changing. We need to have this conversation with the patient community, with the hospitals, and make sure that there is no barrier to a patient specimen being tested so that patient can receive the state-of-the-art treatment based on his or her disease.
The most important thing, I believe, that we learn to work together with other colleagues. And this is for me the first objective reached. Because we learn to work with pathologists, with radiologists, with endoscopists, and we learn to discuss with the patient about the possibility to have a quality and quantity tissue enough to reach more results than non-small cell lung cancer and small cell lung cancer.
It is difficult to get sufficient tissue from patients with advanced lung cancer because we are often dealing with very small biopsies.
Luckily in lung cancer, I think many groups that work with that precious tissue have already realized that. I know a lot of lung cancer pathologists are very much in tune with this. And then the people that get that tissue out, surgeons or pulmonologists or interventional radiologists, everyone's kind of on the same page.
Most of the major academic medical centers in the country, I think, are doing relatively okay at getting tissue for research purposes. My concern would be, how much are we eventually going to translate that into the community and into the regular practice?
Now, what we are trying to educate the community to is to be sure that we have good quality tissue, as more as better, because we need it for this molecular testing.
For some analysis, we can get the right drug. That unfortunately is not the case for all the analysis, because we have some biomarker for which we still do not have the right drug to administer to our patient. And this is for the first part, so we are talking about the diagnostic point of the disease. Another issue is the rebiopsy, so to gain more tissue at the time of the relapse. This is another important point, mainly for those patients who were or who are mutated, for instance, for EGFR. It is important to look at the disease at the time of the relapse, so to discuss with the patient about the opportunity to get more tissue and to decide the good and the right therapy at the time of the relapse.
When you're telling patients that you have to get another biopsy or you have to go for another test, we need to do a better job of communicating why we're doing this, how it's going to make a good impact on the patient's care. And this is where I think the advocates come in. They can actually help explain these things to the patients. They can prepare patients for having these conversations, even if a patient's physician does not recommend molecular testing. I think these days patients should be asking their physicians, has my tumor been tested for EGFR? Has it been tested for ALK? And this is where I think we can all work together.
It is a challenge, but it is also an educational process. It is about a good communication between the oncologist or the pulmonologist or whoever take the biopsy, between the doctor and the patient, and it is about to explain for the patient what does it mean to get this tissue, to get this biopsy. We need to explain clearly for the patient so the patient understands it, that yes, it is important actually to have sufficient tissue to determine which therapy should be given.
We no longer are at a time where you've had a diagnostic biopsy and you've gone through treatments. We're going to use the same information from a biopsy from 2 years ago, no matter what the course of your disease is. That's changing. We are now adopting to biopsies at multiple time points during the course of a patient's cancer.
I think the advocates are extremely important in nowadays, and helping to explain the importance of molecular testing, and the tissue is the issue. Here is a significant role for the advocates.
So right now, the National Lung Cancer Partnership is now serving as the administrative home for the Lung Cancer Mutation Consortium. This is a consortium of a number of major academic centers across the country that really want to test lung cancer tumors for very specific changes in the tumors, whether they're genetic changes or protein level changes, and then match those patients to clinical trials that are most likely to help them have the very best outcome.
Through our sister organization, the Dario Lung Cancer Medical Institute, we are in the process of collecting tissue for late-stage patients, stage 4, through one of our projects called the Castle Project, which is not only collecting tissue from patients, but peripheral blood samples, banking it in a biorepository, and then getting the information back to the patients that we're testing on within 7 to 10 working days, so that they actually can then take that to their doctors for a consult on whether or not they are available for certain treatment options.
It is important that we have the advocates around the table to be sure that we formulate ourselves in a correct way, and we have their perspective to it.
We now are increasingly testing patient specimens for individual events, molecular events. And there is a wide variation in how these tumor specimens are obtained, even within the United States. Core biopsies versus fine needle biopsies. Many centers still use fine needle biopsies, which don't give you adequate tissue to do this kind of testing. So we need to educate the academic community and the hospitals across the center and radiologists and others who do these procedures to think about getting enough tissue.